Well, hello to the audience. My name is Dr. Lawrence de Koning. I'm an associate professor at the University of Calgary in Calgary, Alberta, Canada, and I'm also a clinical biochemist with Alberta Precision Laboratories in Calgary. I'm here to talk to you today about applications of laboratory data to improve healthcare delivery and patient outcomes. One major interest of mine from a research and clinical standpoint is how to use laboratory data to improve both the quality of the operations of the lab, but also the quality to the healthcare experience that patients experience at a hospital setting. So I'm going to give you 3 examples today of projects that we've worked on here in Calgary. And so the first project has to do with how we use glucometers to reduce unnecessary glucose tolerance testing in pregnant women. The second example is how we used some simple tests and very simple data to help reduce and eliminate a great bugaboo to laboratorians at 72-hour fecal fat testing. And finally, how we use simple common laboratory test results to help identify patients undergoing coronary artery interventions who are at high risk of death. 3 projects. Oh, this is the first one. So before I get into it, I'd like to introduce our city, Calgary, Alberta, Canada. We are the largest metropolitan center in the province of Alberta in Canada. We are a city of 1.4 million people. And from a laboratory standpoint, the entire city and surrounding rural areas is serviced by one laboratory provider, Alberta Precision Laboratories. Now, we have labs in all of the major 5 hospitals, characterized by these little green boxes on the map on the left throughout the city. We have small laboratories at about 5 community testing sites throughout the city. And we also have hospital laboratories in rural hospitals, in 9 rural hospitals outside of the city, which are in the blue boxes on the right part of the graph. But probably, the majority of the work that we do in terms of specimen drawing from patients is done at these patient phlebotomy centers, and there's 19 of them, and they're in red, and they're scattered throughout the city, and they're also in the rural areas. These collection sites are responsible for taking blood and taking patient specimens, prepping them for testing, but then transporting them to our central laboratory, marked by a small gray box in the left map, in the number 1. That's our central laboratory that does most of our community testing. So, glucose tolerance testing. This is a big part of laboratory testing for any laboratory system. We do them in Calgary, and we do several different types of glucose tolerance tests. We do a 50-gram glucose tolerance test. It's actually a gestational diabetes screening test. It's part of the 2-step gestational diabetes screening testing program that we have. That initial screening test can be followed up with a 75-gram oral glucose tolerance test for women who test in the intermediate range in plasma glucose after they receive the screening test. And then we also have just a regular old 75-gram oral glucose tolerance test for non-pregnant patients. The majority of these tolerance tests are performed at these 19 patient phlebotomy collection sites that are scattered throughout the city and are found in some of our rural areas too. Only a very small amount, about 10%, are done at our 5 urban hospital sites and 9 rural hospitals. So most of them are done at these collection sites. There's no testing done at these collection sites, only specimen collection. Now, further details on how we do tolerance testing. So at the phlebotomy collection sites, what happens is the patient arrives fasted. A fasting venous blood sample is drawn, and that fasting venous blood sample is opened and tested with a glucose meter. Now, if the glucose is too high on the meter, and I'll get into exactly what that means later, the glucose drink is not given to the patient. Then the whole blood, at that point, the whole blood sample is spun down and prepared for transport. And if the initial glucose result was adequate, then the glucose drink is given and post-load samples are taken from the patient. And then those samples are spun down. And then all the samples are sent to our central testing lab in the northwestern quadrant of the city. And what's being sent is plasma. So the sample is effectively stabilized at that point. Now, to get the testing done, it takes about 4 hours from dispatch of the specimen to the result being populated in the electronic medical record. Now, at our urban and rural hospitals, we don't have the exact same process. Instead, specimens are drawn, spun, and plasma testing is done on site. So you get an immediate result on the fasting sample. And so if the result is considered to be too high, then the drink is not given, and that process is done immediately. And then any subsequent testing of the specimens is also done immediately, so we get an immediate result, and the patient can walk out and know that the results are going into the medical record. So just some review on what we define as diabetes. For non-pregnant patients, we define diabetes according to Canadian Diabetes Association guidelines, which are the same as American diabetes, except that we use SI units. So diabetes is defined as a fasting glucose greater than or equal to 7, an A1C of greater than or equal to 6.5%, or a 2-hour post-load, 75-gram load glucose of greater than or equal to 11.1. You can also diagnose it based on a random glucose of greater than or equal to 11.1, but any positive of any of these results should be followed up with confirmation by another test if the patient is asymptomatic. Well, for pregnant women, when we're trying to diagnose gestational diabetes, we use the two-step procedure that starts with a 50-gram load in the center, box 50-gram glucose load with 1 hour post-glucose testing. And depending on their glucose result, after that, they can be negative on the far left swim lane, they can be positive on the far right, or they can be intermediate between 7.8 and 11. If that happens, then they are referred for a 75-gram glucose tolerance test, where we test post-load glucose at 1 hour and 2 hours. But before all of that, we actually do a fasting glucose. And if a fasting glucose or a 1 hour post-load glucose or a 2 hour post-load glucose, any of them, if they are elevated, then gestational diabetes is diagnosed. So I want to draw your attention to the fasting glucose greater than or equal to 5.3. So even before any post-load glucose testing can be done, we can diagnose gestational diabetes in these patients. So back to the drink. Why should the drink not be given? Well, I've alluded to that. But first of all, it's actually quite inconvenient for the patient to have to consume the drink and then wait around for 2 hours and subsequent blood draws to figure out if they have gestational diabetes or not, or just regular diabetes if they're non-pregnant. There's also a certain amount of discomfort and risk associated with tolerance testing. There's blood collection that's involved. In pregnant women particularly, they're susceptible to vomiting and nausea. These are the major causes for canceling these tests. And there is a small risk of hyperglycemia or post-load hypoglycemia due to overactive beta cells and hyperinsulinemic response. And there's some costs associated with the lab as well, which we're very cognizant of, being part of a public healthcare system in Canada. There's costs in consumables, there's costs to do the testing, and there's actual staff being involved in the testing, which prevents other patients from being seen too. And the patient occupies a chair at the collection site, which could be taken by another patient. What is considered to be too high on that glucose meter at those collection sites? Well, for the non-pregnant tolerant tests, we basically have a cutoff of 7.9 millimoles per liter or greater. And if that is exceeded, then we don't give the drink. And we came up with that because it's 7.0 plus 0.8. And the 0.8 is the whole blood meter versus plasma core lab bias that we see. And the 7.0 is the threshold for diabetes. But for the pregnant tolerance tests, we at the point of this project didn't have a cutoff for denying the drink. So our objective was to define a meter cut point with adequate sensitivity and specificity for gestational diabetes by fasting plasma alone. And the fasting plasma result alone would be greater than or equal to 5.3 millimoles per liter. So we can make a call of whether a patient has gestational diabetes right away if we can implement that cut point. So our methods were, first of all, to obtain all of our whole blood fasting glucose meter results. We link it to the plasma fasting glucose result from the same tube of blood. Remember, we're testing them on both the meter and the lab. And then perform ROC curve analysis to identify a fasting whole blood meter cut point that has high sensitivity and specificity for that fasting plasma glucose of greater than or equal to 5.3. The meter cannot be used to diagnose gestational diabetes but if we set a threshold high enough, we can probably predict whether someone's going to go on and get a plasma result of 5.3 or greater. So this is just a Bland-Altman plot showing the relationship between the core laboratory plasma glucose on the bottom and the difference between the two on the y-axis. And all it's showing is that our glucose meters are overestimating plasma glucose on the low end of the lab result. And so I'm not going to show you the gory details of the ROC curve analysis, but at the bottom, highlighted in yellow, is the cut point of 5.2, which is actually greater than or equal to 5.3. And that cut point on the meter has a sensitivity of 91.4 and specificity of 91 for a plasma glucose of greater than or equal to 5.3. And so over a 2-year period, we end up identifying 323 women who actually have a plasma glucose over or equal to 5.3 using that meter cut point. So that's great. So those women can be, they don't have to have the drink at all. So that's an improvement in their experience going to the collection site. But there's 370 individuals who are denied the drink inappropriately, and those women are going to have to come back for retesting because that cut point is not the best based upon the number of women that we test. And so there's another cut point that we looked at too, and that's 6.0. So it only has a sensitivity of 25%, but a specificity of 99.9%. And that one we called 88 individuals over 2 years, if we use that cut point, who would be appropriately denied the glucose drink. And over that period of time, there are only 3 individuals who we inappropriately denied it to if we would have implemented it. So this was, all this data is showing what we would get if we implemented these cut points. It's based on our existing data. So we looked at this data and thought to ourselves, what should we put into place here? And so we had to talk to the endocrinologist to discuss with them what would be best. And we all agreed that using a cut point of greater than or equal to 6.1 or greater than or equal to 6 was better because there were only 3 false denials of the drink per year. Basically individuals that had an error in this process, meaning they would be denied the drink inappropriately, they would get an automatic callback through a laboratory information system rule that we built so that they could come in and get an appointment for retesting. So that was a nice outcome of implementing this cut point. And so we actually did implement that 6.0 cut point. We also implemented the cut point of greater than or equal to 5.3 on all of our hospital labs for that fasting sample that's done on site. We didn't have to worry about a ROC curve analysis because we are testing plasma glucose. And so we say, okay, if their fasting result is 5.3 or more, then it's a diagnosis and we don't need to do any further testing so the patient can go home. So this was a very nice result at the end of the day. So by these 2 changes, we save about 145 women per year from having to get the glucose drink. So this is a great outcome. And it saves the lab about $10,000 a year. So this has been published in the May 2019 edition of the Journal of Applied Laboratory Medicine. So you can read more about it there. Now, the second quality improvement study using data I'd like to show you is a project we embarked on regarding 72-hour fecal fat testing. So this test is a very old test. It came to be 4 years after the end of the Second World War. It's a manual test using large quantities of acids, bases, and solvents, it requires the patient to go sort of on a fat treadmill. They consume a high-fat diet for a total of 5 days, and the last 3 days of that diet, they collect their stool in a paint can. And the whole purpose of this test is to identify fat malabsorption and maldigestion. In children, the high-fat diet is recommended, but not expected, and so dietary intake is measured with a dietary assessment tool, and fat intake is calculated based upon that and compared to the fat output that we measure in the 72-hour collection. So this is what it looks like. So you start with a stool specimen in a paint can, and then you dilute it in water. And then you add rocks to the can and shake it up in a paint shaker to make a slurry. And then you extract the stool fats, which are mostly in triglyceride format at that stage, in ethanol, and you add to it a very strong base and warm it, and that creates soaps. It turns breaks down the triglycerides into fatty acids and glycerol, and then converts the triglycerides into fatty acid soaps, or the fatty acids into fatty acid soaps and glycerol. Then you add hydrochloric acid to convert the soaps back into fatty acids. You protonate them. You do it on ice because it's an exothermic reaction. And then you extract those fatty acids with petroleum ether while shaking vigorously. And then you evaporate the petroleum ether in a hot water bath, leaving fatty acid crystals behind, which you solubilize in ethanol. And then you add to it a pH indicator and titrate it with the strong base until you get a nice blue color. And the amount of base that you titrate in millimoles is proportional to the millimoles of fatty acids present in that aliquot, which then you can use to back calculate the total amount of fatty acids in the original 72-hour stool specimen, and then you can express that result in millimoles excreted per day. Now, we did have two reference intervals for this test. For patients under 7 years of age, what was considered to be normal was less than 7 millimoles per day output, but for patients greater than or equal to 7 years of age, it was less than 21 millimoles per day output. We had a separate reference interval when comparing fat intake versus fat output as a percent. These are for those children that are assessed by a dietary assessment tool, a diet diary, and that was 0 to 9.9%. But most of our testing, our reporting was the millimoles per day. So some interesting information historically on the metrics performance on this test. So our turnaround time for this test was 2 weeks from receipt of specimen to reporting result. And we eventually moved to 1 month turnaround time when we made some changes to it. And it was a very labor-intensive test, as I've mentioned, but it took one staff member an entire shift to report out 9 results, which is really low output. The test had 20% variation in the results month to month in our quality control pools, and our run-to-run variation was 10% in specimens that we would run and carry over from the previous run to the current run. So the maximum total imprecision of this test was 22%. Not very good when you compare it to automated chemistry analysis. Other interesting things about this test is we were not evaluated by any agency for our performance relative to our peers, just because one did not exist. There was no proficiency testing scheme. So impacts of this test, well, it's difficult for patients to collect their stool for 3 days, but also difficult to go into a high-fat diet for 5 days. They also write down their diet on a piece of paper, regardless of whether a child or an adult. And for the adults, that information was not used. For the kids, the diet has to be recorded by the family for those days, and stool collection for a child is rather difficult. I suppose it's easier if they're in diapers, but it's still not easy. And it's hard for staff. There's significant biosafety controls, chemical hygiene controls. It's a manual procedure. And then if we are doing intake versus output, input versus output in children, we have to have a dietitian involved to make sure that the total fat intake is calculated properly from the diet data. Lots of problems in terms of interpretation. So we'd often get incomplete collections. Any patients who actually were experiencing steatorrhea, their response to that would be reduce their fat intake to make their life a little bit more pleasant. Diarrhea itself, this is a lesser known fact, actually increases fat output no matter the actual pathology that causes it. And then the final step, the titration step, the variation associated with that measure was actually surprisingly large. And most of this information was summarized in an audit that was done in the late 90s and published in early 2000. And the bottom line from that audit, that British audit, was that this test makes it a very unsatisfactory investigation, and the performance of it certainly, and probably of little clinical value. So when we were looking at this, this test was identified as one that could be probably not done. So this is about 15 years after this came out. So there's lots of alternatives to this test. That's another point of this article. And I'm not going to get into too many of them here, but basically we have other tests in the lab that can be used that are simpler, that can help rule in or rule out fat malabsorption and maldigestion. There are some patients that you just don't want to do this test on. They're probably not eating enough to have sufficient fat intake to begin with. Patients with frank pancreatic insufficiency, it's not really useful to do this test. And then if you're just trying to diagnose it and the patient has gray and greasy stool, I don't think you need to do any other testing, save maybe confirming fat globules that are present in the specimen. So our goal was to, first of all, reduce the amount of fecal fat testing done in their lab and hopefully replace the test because it's a really bad test and not that helpful for clinical investigation. So what we did was we, first of all, pulled all of our utilization data for fecal fat. We looked at ordering patterns to determine if we can, immediately institute some restrictions for a quick win. And also we performed some research on the existing data in the lab information system to see if any characteristics of the specimen can predict abnormality by the Van de Kamer test. And we also did some testing of bank specimens to see if those results from alternative tests would help. So first thing we found out was that in these bar graphs, the majority of the tests that were being run were on patients who were adults, greater than or equal to 18 years of age, and that's inappropriate. This test was really designed to pick up extreme fat malnutrition in kids, so we instituted a ordering restriction before 2015, and that reduced our ordering of this test and our testing of this test by 80% right off the bat. So that was a very quick win, but we still had some residual ordering in kids and adults. And so we decided that this test could only be done by permission, by consultation with myself, and any specimens that arrived at the lab that were not pre-approved by myself, they would be screened with a microscopic investigation for fat globules. And we found that when presented with these pos-neg results, the clinicians admitted that they probably didn't need to do any further testing. And sometimes we would, in a later stage of the intervention, we just started to run this test reflexively and reporting the results, and the physicians never complained. And when asked about it, they said, well, we probably never needed the fecal fat Van de Kamer test originally, so this is a good move. In terms of the data, how we use it, we looked at whether the weight of the specimen could predict abnormality by the fecal fat test itself. So this is an ROC curve analysis of the specimen weight, the 72-hour specimen weight, versus positivity using the 21 millimole per day cutoff for patients that are greater than or equal to 7 years of age. And the first thing you see, is it's not a bad ROC curve, and the C statistic or area under the curve is 0.74. So that's actually quite high for something as simple as the weight of the specimen as a predictor of abnormality. And if you go along this curve and you look at different cut points, say 486 grams, 555, 606 grams, we start out very sensitive but not very specific, and as we increase, we get more specific and less sensitive. That's of course what happens. But the point of this is that we had options of setting a cut point based upon a chosen sensitivity and specificity, and that could be chosen in consultation with clinicians. Similar results if we just look at the under 7 year of age group with 7 millimoles per day excretion. So we had multiple different cut points with appropriate sensitivities and specificities that we could choose by using weight alone. And then when we actually looked at some of the specimens that we banked for these patients and tested them for the presence of fat globules microscopically, we found that adding microscopic assessment for fat globules on top of fecal weight in terms of predicting positivity by the Van de Kamer test, it improved the prediction. It went from 0.70 to 0.74 for area under the curve, so that was quite satisfying. And so everyone was in agreement that we could replace the Van de Kamer test with an assessment of weight and an assessment of fat globules and just put out this big comment which says the following about the specimen, that the weight is, and we enter the result, the technologist enters the result and decides whether it's high or normal, and it indicates the upper limit of normal for that test and the appropriate sensitivity and specificity, and then some further information about fat globules and to contact myself if there's any problems. So this also has been published. This was published in May of last year, and you can read about it in the Journal of Applied Laboratory Medicine. So the final 6 minutes of my talk I'll use to describe my final application of laboratory data in quality improvement. So this was actually using common laboratory results to predict risk of death in patients undergoing coronary catheterization. So, what's interesting about acute coronary syndrome patients is that they can be discharged from the hospital, but then die later, days or weeks after they have their initial catheterization. And here's some statistics. The risk of death 30 days after initial ACS episode is 4%, but by 6 months it's 8%. And if they're readmitted for a cardiac cause, their risk of death goes up enormously. And so basically the idea is that you want to keep patients in the hospital initially that need it and discharge only those patients who are going to stay healthy or stay healthy for as long as possible. If they come back to the hospital, there's higher morbidity, mortality, and there's a greater impact on the healthcare system. And in Canada, we know that up to 60% of these unnecessary readmissions may be preventable by being more careful in how we assess the patients while they're in hospital. Now, one solution from the lab is actually to use existing laboratory data to identify those who are at risk. And of course, the question is, are we missing gold in our backyard? That gold being simple stuff that's already in the electronic medical record, the results of very simple laboratory tests. And so this is a big area of investigation by a number of hospital systems in the U.S. and also in different locations within Canada as well. So our objective was to use common lab data, and we're talking CBC, electrolytes, to estimate risk of death in these patients and contrast that risk and how well the risk is assigned to the patients, the efficiency of it, to the assessment that's used traditionally, for these patients. So assessment of clinical risk factors, smoking status, presence of comorbidities, body mass index, family history, previous MI, these sorts of things. And that'll tell us whether that risk assessment via lab data is useful or not. So all we did is we pulled all available laboratory test data on patients undergoing coronary catheterization, and we linked it to a cardiac registry that had follow-up data on mortality and comorbidity data that we could contrast the lab data to. And then we determined the associations of lab test results with mortality and created a cumulative lab risk score that summarizes the cumulative impact of all the different lab results on mortality risk. And then we validated that lab risk score in terms of its performance in a different geographic location to be sure that it actually works. So this is a theoretical graph of the course of admission and discharge for a patient who comes in with an acute coronary syndrome. They're admitted, they have labs, they may have other labs, they have other assessments on the left. Once they hit the red box, then they're having their final set of labs and examinations before an invasive procedure, coronary catheterization, stenting, and then perhaps after the procedure, there's post-procedure labs, other investigations followed by labs before discharge. And, then there would be an outcome occurring at any point during that process, but hopefully long after they've been discharged. The simple lab tests that we considered in our analysis were just the CBC with differential electrolytes, creatinine as calculated by the eGFR, total CO2, and INR. And we put these data into a logistic regression model, the data being quintiles of each of the different lab variables. And we essentially used a backwards elimination technique to kick out variables that were not significantly associated with mortality risk in the linked data set after adjusting for the impact of the other lab data. And so what ended up in the final model were things like sex, CO2, sodium, eGFR, white blood cell count, and INR. Most of these are obviously quite important in the assessment of patients, but their associations, as indicated by the odds ratios, some of them were unexpected. For example, the higher the sodium was, the lower the risk universally for mortality for the patient, and that may reflect a medical response while they're an inpatient, or it may just be the provision of fluids and more intense medical care to the patient. And so what we did with those associations in the final model is we created a cumulative score, a lab risk score. And this logistic regression model, it's basically just a formula that adds the individual contributions of each predictor, age, sex, and all the lab variables to create an overall risk of death for the patient. And if you multiply those coefficients by a constant to make the score large and easy to work with, you can get a final number for that patient, maybe 0.5. And if we divide those scores into quintiles, you can graph them like this. And you see as you increase the quintile of the lab score, you increase their risk of mortality quite substantially. Unadjusted, there's a 40 times higher risk of death in these patients in the top quintile versus the bottom. And what we found is that the C statistic, the overall performance, calcification performance of this score in Calgary in the validation population was very good and almost as good as the demographic and clinical risk factors. And this performance was almost the same in Edmonton, our external validation location. So lab data is powerful. And this paper was published also in the Journal of Applied Laboratory Medicine last July. So our overall conclusions is that, first of all, quality improvement requires good data, which we have access to in Calgary. You have to be able to work with data very well in order to get a conclusion, but it's really fun and extremely rewarding. So thank you for your attention. I hope you found this talk interesting.